Good morning and a very warm welcome to the GPE webinar series. My name is Jane Davis and I'm Senior Education Specialist for Gender Equality at the Global Partnership for Education. I'm here at the GPE Secretariat in Washington, DC, joined by my colleagues, the GPE webinar team, who've brought us this webinar today. We're also joined by a distinguished panel of experts presenting online from London and here in the Secretariat. The webinar series, which started in 2016, is part of GPE's Knowledge and Good Practice Exchange initiative that came about in response to requests from GPE's partner countries for opportunities to exchange global knowledge, good practice and policy approaches that can help inform improved education policies and practices at the country level. The webinar series provides a forum for interactive dialogue between practitioners and partner countries and shines a spotlight on the innovative work being done across the global partnership to deliver better education results for every child and to fulfill our shared vision of SDG 4. In choosing topics for the webinar series, GPE explores themes related to our strategic goals: learning, gender equality, equity and inclusion, system strengthening and partnership building, as well as approaches for translating global commitments into country-level actions in line with our strategic plan and gender equality policy and strategy. Before we begin the session today, may I highlight a few housekeeping notes. Please be sure to mute your microphones on your phones and computers to cut out any background noises. If you're facing connection issues, please let us know via email at webinars@globalpartnership.org. You can also ask your questions via email as well. We'll have a Q&A session after every 2 presentations, so do keep sending your questions throughout the webinar, either via YouTube's live chat feature or by email. We'll try to get as many questions as possible during the Q&A session. Please mention your name, your organisation, and the name of the presenter or speaker to whom the question is directed. This session is also being recorded, and we'll send everyone participating today resources associated with the webinar and a link to the recorded session. Today's session will focus on a new GPE World Bank publication, Optimising Education Outcomes, High Return Investments in School Health for Increased Participation and Learning. The publication draws on the latest evidence and analysis available in a broader volume, Volume 8, of the 3rd edition of Disease Control Priorities, also known as DCP3, which looks at child and adolescent development and provides clear evidence of the positive benefits of investing in health using the school as an effective platform, especially for adolescent girls. It illustrates why we in the education sector need to take note. The analysis makes clear that achieving long-term goals in health is critically dependent on an educated population. It also crucially demonstrates that children cannot learn if they suffer from the effects of poor health and nutrition. In low and middle-income countries, for example, children miss an estimated 500 million days of school due to ill health, and this negatively affects their concentration, growth, and learning. Strategic investments in health using the school as an effective platform boost both health and education results and provide a cost-effective means for moving forward to attainment of the Sustainable Development Goals. The DCP3 volume identifies key health interventions that have been proven to be worthwhile investments for different age groups, early childhood, school-aged children and adolescents, and which are relevant to the different needs of boys and girls. We'll be hearing from the panel in just a moment about the specifics of these health interventions and their significance for the education sector. But before that, allow me to introduce to you the distinguished guests on our expert panel today. Presenting from London, we have Professor Donald Bundy, lead editor of Disease Control Priorities Edition 3, Volume 8, on child and adolescent health and development, and who is also professor at the London School of Hygiene and Tropical Medicine in the UK. Also in London, please welcome Dr. Leslie Drake, Executive Director for the Partnership for Child Development at Imperial College London. Here in DC, Ms. Alice Albright, Chief Executive Officer of the Global Partnership for Education, will be joining us later this morning. And finally, Ms. Linda Schultz, Health and Education Consultant at the World Bank headquarters, also here in Washington, D.C. So may I first of all hand over to Professor Bundy to introduce the DCP3 Volume 8 on Child and Adolescent Health and Development, and to outline the key messages emerging from the volume which have important implications for education sector planning and investment. Thank you very much, Professor.
Well, thank you very much, Jane. It's a real pleasure to be joining this webinar, and I already know there are several good friends who are participating on this. So welcome all. The Disease Control Priorities Network today actually announced the new volume on the education sector that Jane just talked about. The volume sponsored jointly by GPE and the World Bank. I'm going to talk a little bit about what disease control priorities analyses are all about and why the education sector decided to become engaged in those issues. And then Dr. Drake is going to follow up talking about some of the specifics of interventions around school health. So if I can have my first slide, please. I'm not seeing any change at this end. Is that change? Perfect. So disease control priorities. Let me give you a little bit of history. 1993, the World Bank published the World Development Report on Health, which was called Investing in Health, their first World Bank report on health. It's an edition that became really quite important in all sorts of interesting ways. It was put together by Dean Jameson as the lead editor, and overseen by Larry Summers, who was then the chief economist at the World Bank, and then of course went on to other things, including Secretary of the Treasury in the US. Bill Gates says that this volume, the 1993 Investing in Health volume, was the reason he focused the Gates Foundation on health rather than any other topic, because what the volume showed was what were the returns to investing in health, including, very embryonically those days, how those returns also benefited education. Moving forward to 2006, a second edition was produced, Disease Control Priorities Volume 2, a lot bigger than Volume 1, but not as big as the third edition, which has just been published 30 years later, which is actually 9 volumes. And what we're going to talk about today is one of those volumes, the volume that focuses on child and adolescent health and development. Just at the end of last year, when we launched this third edition of Disease Control Priorities, the guest of honor at that was the Director General Tedros from the World Health Organization, and he said thank you for these volumes, because here I have a set of books that contain analyses that I can point to being neutral in making decisions about how we invest in health. And that's exactly what this series was about. That's what DCP is about. It's about producing a neutral consensus around some specific areas in health. And if I just show you the next slide. The next slide shows all 9 of the volumes and highlights volume 8, which is the one on child health and development. And I want to emphasize here that what we have is a set of books which are all analyses based on economic returns to investment, and that there are a set of books that covers most of the health areas, the majority of health areas, but is not at all intending to be a set of books that's that is a health textbook. This is about something that can be used, just as DG Tedros said, it's something that ministries of finance use, and since 1993 in my travels. I've seen these books very frequently on the desks of not on the shelves, but on the desks of ministers of finance, and and indeed ministers of health, as their way of deciding what are priorities or backing up their thinking around priorities. And I think 30 years is a pretty good test of whether something's useful or not. I have the next slide. Preparing something like this is not a straightforward process. It's 9 volumes, 7 years, 33 editors, more than 500 authors. But the fact that so many authors are involved is important, because this is meant to be consensus. It isn't about one person's vision. It's what does the field think. And also, I think quite extraordinarily, the whole series is peer reviewed by the Institute of Medicine for the same reason, so that we make sure that that there's a broad view. I could have the next slide, please. For the first time, this is also just to say that the policy forum also involves face-to-face meetings, and I just wanted to reflect on 3 meetings we had with the Africa Union, with China, and in the Middle East and North Africa discussions with WHO. Again, just to give you a sense that this is a living document that's been produced by a process of consensus building. Next, please. And okay, so this is the one I want to focus on. It's got a foreword by Gordon Brown, who led the UN Commission on Education Finance, but its focus is on the broad areas of adolescent and child health and development. Next slide, please. So many of you will be very familiar with this slide from Nobel laureate Professor Hickman, that's been used to make the case for investing very early in child development. It's a slide with age on the bottom axis, and then on the y-axis, the rate of return to investment. And Professor Hickman used this as a slide to make the specific point that if investment very early in life had the highest return, then clearly that's where we should be investing. And in this volume, in our reanalysis of these questions, really the question we pose is that correct? Is it really only at the beginning of life that investments have that high rate of return? And in fact, we will make the case that there's a high rate of return at several points during the early development of a young person, and that in fact the trajectory of that line is not strongly downward, but probably much more horizontal. And why do we think that? If I have the next slide, please. This is just to give some illustrative presentation. So next slide, please. An illustrative presentation of the kind of data that we've looked at. As I say, this is a volume with 30 chapters and 110 authors. So we've gone into depth on these issues, but just to give you a sense of what this is. So we're looking left to right is age from 0 to 20 years. And then on the y-axis, we're looking at various changes. If we look at the top panel, that shows growth in height. And what we see is that when babies are first born, that of course there's this dramatic increase in growth. That tails off. But then there are these 2 peaks for girls and for boys, caused by around puberty. And we can see dramatic changes occurring there. In fact, if we take males at that point, they're growing at the same rate as they were when they were 2 years of age. But of course, they're massively bigger in terms of biomass. So the changes that are going on in straightforward biomass terms are very dramatic. But we also know, of course, that all the pubertal changes in behavior, in attitudes, and in mental state and social state are also happening at the same time. And I'm just simply using that as a particularly dramatic example of a phase of life where investing in health and good nutrition is very important for child development. And we also discover that there's lots of catch-up that can happen there for children who didn't have benefits earlier in life. Below that, the panel is talking about different parts of brain development, and just showing that brain development's a process that happens throughout the 20 years. And to emphasize that, the final panel at the bottom there looks at sizes of different parts of the brain. Now, if you were taught about brain development more than 15 years ago, like I certainly was, then we were told that when kids were born, they've got big heads because the brain's pretty well all there by the time they're born, and the important part is before that. But what we now know through a huge change in the way in which we think about brain development is that there are massive changes towards the 20 years of age. That there are the changes occur in two particular areas. One is so-called synaptic pruning, which means that the connections in the brain are being pruned, are being refined, so that those you use are strengthened. And also myelination, which means that more effort is being put into laying myelin around the neuron, so that those you use most often transmit faster. We know that those ages are exactly the ages where mental health issues first emerge. We also know that these are the ages of experimentation. All the classic stories about adolescence are about that age. And also, this is also the period when you fix your behaviors lifelong going forward. So this is a vitally important area of development, and yet one that we've tended to neglect. So our conclusion then is that the 0 to 20 years are full of important phases, crucial phases as a child develops. Have the next slide, please. And one of the extraordinary things we found when we started to do this work was that we really have no very simple, no agreed descriptions for many of the age groups. For example, the area of middle childhood, which we characterize as 5 to 9-year-olds. Middle childhood is a term that's well known in the psychological literature, but we really didn't have a term. The term child could mean so many things. For many people, child meant somebody under 5. And we had the same sort of problems deciding about late adolescence and early adolescence. So one of the issues in developing this text was to get agreement as to what were the important areas and what was a common nomenclature. Can I have the next slide, please? This is where I'm going to mention that we have two essential packages that we came up with between 5 and 19 years of age. A school age package delivered through schools for 5 to 14-year-olds, and an adolescent package from 15 to 19 years, involving secondary schools, but also the media and health systems. And Professor Drake is going to talk about those in a moment. Have the next slide, please. So when we started to think about what these packages would look like, we discovered that there's been a good deal of thinking going on in that area already. So this is from the World Bank, and what it's looking at here is to look at a sort of standardized vision of what age and school attendance looks like, and to set that against a variety of health interventions and when they would be most usefully provided. In other words, the implication of this is that health needs to be delivered throughout the first 20 years of life, but also it has to be delivered for specific interventions. And a great example of that is China. If I could have the next slide, please. So in China, this is the set of programs that are used both by the education and health sectors at different points in the development of a child. And they show how if we look across the first 8,000 days of life, there are several different sorts of interventions that need to be brought into play. And I should say that this is a real program. There are 44 million children as part of that program receiving these different interventions. And then the next slide, please. So what is the implications of this around the education sector? Well, here's a graph that's intended to illustrate to you some of the key issues which show that that there are several different types of interventions that matter for educational outcomes. Everything here is an education outcome. These are bubble graphs, bubble charts. Ones that are in red are about health interventions. The ones that are in blue are about incentive-based interventions like changing school fees and providing cash incentives. And the green ones are about education interventions. But I'm going to say again, the outcome that's being measured is education in every case. And the important message here, and I'm not saying these are terribly precise results, but the important message here is that changing things in health, changing things in incentive also have impacts on education that are of a similar order of magnitude to education interventions. So improving education isn't only about improving education interventions, it's also about health, and it's also about providing social incentives. And so that's what that's saying, is that health matters for education. But in the next slide, please, I also want to emphasize how much education matters for health. So this is looking at female schooling over the period 1970 to 2010. And over that period, there's been a massive change, massive decline in mortality rates. And you can see here an attempt to look at what are the contributions of female schooling to that. And we can see that for under 5 mortalities, one of the great MDG success stories, there's been a 14% contribution from education. And then if we look at adult and male mortality reduction, we see that about a third of that is attributable to improvements in education for women. So that's giving the other side of the same coin. So one side is that health improves education. The other is that education very substantially improves health. And the next slide, this takes us to why GPE has formed a partnership with the World Bank so next slide please, to publish the key findings from this volume in a volume of their own. And for this volume, and the volume produced by GPE has a preface by Julia Gillard, the chair of GPE, as well as a prologue by Louise Banham and Brad Strickland and Leslie Drake, who's going to be talking about this next. So that's a really very positive change. And one of the things I always say rather blithely here is that nobody in the education sector is going to read something called disease control priorities. So what this one is called is optimizing education outcomes, high return investments in school health for increased participation in learning, and it's specifically focusing on that. So finally, let's look at what are the economic implications of all of this, because I think in a way this is where the rubber meets the road on all of these issues. And what we did was we did an analysis of low and lower middle income countries. Have the next slide, please. Low and lower middle income countries to get a sense of what was the current level of investment. And it's quite dramatic to look at this. So this is a graph showing age on the horizontal axis. We can see up to the age 5, about $29 billion a year are invested by low and lower middle income countries in children under 5. That's mainly an investment in health. Over the age of 5 up to 20, we can see that the investment in education is around $20 at 210 billion, while the investment in health and nutrition for that group is less than 4 billion. Now, what does that tell us? First of all, I want to say that all of these numbers need to be bigger. This isn't an argument for moving those dollars around. But what this does show is that those under 5, in terms of health, are getting a much higher investment than those over 5. And that the investment in education is not being reinforced by higher levels of investments in health. And our estimation is that we need to at least double the investment in health, so probably another 3 billion a year from 5 to 20 years of age to really make a change here. But it also says very clearly that there's incredibly good return on investing in health in those 5 to 20-year-olds, because you're leveraging $210 billion in education. So this is a very strong argument. The distribution here is a very strong argument for investing more in all of the issues that are raised there, whether it's under 5s or over 5s. But it's also a particularly strong argument that we need to invest more in the health and nutrition of school children and adolescents if we're really going to achieve the outcomes in education that we've been looking for. So, overall message is this: we've been doing a great job in the past in thinking about the first 1,000 days of life. We need to do the same sort of job in thinking about the next 7,000 days of life, from 2 years right up into the early 20s. So I'm looking now to conclude that the first 1,000 days are not themselves sufficient, and that we need to have much more action and indeed research on children above 5 years of age through middle childhood and into adolescence. That's what I wanted to share with you, and I guess we'll have questions in a minute, but I'm going to hand over now to Leslie Drake to take the next part.
Thank you very much indeed, Professor Bundy, for your very informative overview of the key messages of DCP3 and the significance of the volume for us in the education sector. Before we have questions, we're going to have one more presentation, and I'd like to turn next to Dr. Leslie Drake, Executive Director for the Partnership for Child Development at Imperial College London, to introduce the platforms for health service delivery and essential packages of investments with a focus on schools and school-aged children. Thank you, Leslie.
Thank you, Jane, and welcome all. And this is a wonderful moment for us all to join together to see how we can make this move forward. If you could just give me the next slide. So this is a real turning point in terms of looking at education outcomes. You can see that the senior editors, with a foreword by Gordon Brown, but also with a preface from Julia Gillard. So this is the education focus. And from DCP3, what we've done is taken 15 chapters of the overall volume to just focus on the education piece. And this has been put forward, by Louise Banham, Brad Strickland from GPE, and myself. And so just want to focus on this piece and see where we go with it. Next slide. So as Don has really kind of given the specific general overview, I want to just look at 2 specific points. I want to look at the policies and platforms to promote child and adolescent development, and also the economics of child and adolescent development. And so really kind of drill down into some of the things that really make a difference at country level. Next slide. So there is a specific chapter that I would welcome all of you to read, chapter 20, looking at the school as a platform for addressing health in middle childhood and adolescence. This looks to how the school is such a stable platform that we should really be reinforcing, making sure we're making the most of it. So please do read. Next slide. So what do we mean by school health? So here's a slide that I really love. It shows the school as part of a community. Every school, every community has a school, whether it's under a tree or it's in an urban environment with 1,000, 2,000 kids. And the pillars, as you see underpinning this, is policies, safe water and sanitation, school health and nutrition services, and health sanitation. And that needs to be in policy. And in many, many countries right now, school health and nutrition is being reinforced under these pillars. But why I like this diagram so much is because it shows what's going on in the school. You can see kids learning in school. You can see kids feeding in school. You can see them having health interventions in school. But you can also see that the parents are engaged. The parents are bringing the kids back to school, whether they're on the accessibility issue or whether the parents have been provided with contract to provide food, which I'll get back onto later. It's part of the community, and we really need to look at this. When we're not saying that schools can do everything, and we need to get those back to the other centres, but we can start with schools, and it's a strong platform. Next slide. So why would we be looking at this? So when DCP3 put its pieces together, we're saying that basically if you look at low and middle income countries, you're losing IQ points just by not treating for worms. 3.75 points just by not deworming. 6 points by not treating anemia. And if you put these school-based interventions together for poor girls and boys in areas where worms and anemia are prevalent, you can lead to 2.5 extra years of schooling for these kids losing out. And I think that is the most significant thing I've seen in a very long time. And these are simple interventions. Next slide. So what the DCP3 team have put together is 2 essential packages for 5 to 19-year-old children. The volume proposes 2 essential packages. First, the school age package, which is looking at what we can do in the schools. The 5 to 14-year-olds, it utilizes pre-primary and primary schools to address basic health needs in middle childhood and early adolescence. And then we've got this new piece that's coming in, and we've not really looked at this before, but the Adolescent Package, the 15 to 19-year-olds. And this is not just about schools, but schools play a role. We're looking at involving the community, the secondary schools, media, and health system. Next slide. So this is the package that DCP3 team has put together for the 5 to 14-year-olds. And you can see there's if you look on the left-hand column, you can see school feeding, health education, vision screening, deworming, TT booster, tetanus booster, and hepatitis and HPV vaccination. And these are just things that we know how to do. And it's a way of just providing a strong platform to build more on. And what we can see is that this can all work, and it's not everything. It's just a basis from where we can build a stronger platform for. And where do we start? And countries are starting to do this. And so let's learn from the countries, learn what their challenges and their successes are in terms of making this work. Next slide. Just move on. Next slide. And then let's have a look at the Adolescent Package. This is for kids that hopefully would have received or the school age package, but how do we work with the adolescents? It's clear that we need to do that. It's clear that it's a cost-effective way of dealing with their issues, but it's not just about schools. So we need to be engaging more with media and adolescent-friendly health services to embrace these kids as they move forward in their lives. But the piece in the schools is health education. And how do we get the right messages to the right children, not just in primary, but in secondary education, and in my opinion, also in vocational training and tertiary education. So, how do we, as Don was saying, we're not looking at the first 1,000 days, we're looking at 8,000 days. We need to be looking at how do we put together a package that health and education work together to provide what these children need to become young adults. And that is clearly what DCP3 has put together is 8,000 days. Next slide. So here's a slide looking at costs. So you look at the benefit ratios for the school age. So let's get back to the school age piece. It's not just let's look at something that we all know and love, as opposed to something that we need to embrace, which is the adolescent piece, and we'll get back to that. But if you look at the benefit of some of these interventions and you look at the costs, you're looking at very big benefits for very simple interventions. And then you're looking at things that cost a bit more, but they're all affordable. It's all within the budget. But they're not going to cost a lot. And putting the whole thing together, in my opinion, if you put deworming and school feeding together with an oral health promotion and you put that with malaria prevention, you're looking at reducing your costs by having an integrated package. And so we need the health people to tell us how best to do that with the education sector taking it forward. Next slide. So let's have a look at the cost share of the school age essential package. In low income countries and then low middle income countries, you can see that most of the costs come from food, but most of the other things can be relatively low cost, and the summation is that in low income countries it costs $10 to provide this essential package per child per year. In low and middle income countries, it falls it costs $24. That can be put into the education budget, no question about it. So it's an affordable range, and some of the interventions are much cheaper than others. Now, we might want to think that school feeding is more expensive than the others and perhaps more complicated than others. But let's have a look at how school feeding works as a platform, as a strong platform, and how that addresses the SDGs. Next slide. So school feeding, as you saw, looks rather expensive, but school feeding programs has multiple effects. You hear about school feeding just being about health and nutrition, about diet, growth and development, but it's much more than that. It actually, in terms of education, it's clear, and we've seen this from cases in Ghana and Nigeria, for example, Ethiopia, that there's an increase in enrollment in learning and girls' education. And so a specific point from Ghana made me a little bit surprised to see that maths and literacy went up with schools in Ghana when they were part of the school feeding program. But not just that, but for girls especially. And so that's an important point. So it's not just about health and nutrition, it's not just about education, but it's also about social protection, because when you look at how countries invested their monies in times of crises, they always put money into school feeding programs. And it's about protecting the children, getting them into school, getting them an education, and getting them fed. But the other thing that's come out is that there's an injection in rural economies as well. And even over a small period of time, we're looking at 3 years, that linking smallholder farmers to specific points of providing food to the school feeding program has changed their livelihood income. And I've double-checked this information, and it is clear that the local economy is thriving through this. And it's not just about the school feeding, but they're also understanding how to get to further market and expanding their own market. Next slide. So I just want to focus now on 3 school health and nutrition success stories. Personal favorite, school feeding, but also vision screening and deworming. So let's go for those. Next slide. So going back to school feeding, it is promoting agricultural development by improving access to the school feeding market. It is a win-win for both the children and communities, improving everything. And smallholder farmer livelihoods are going up. And I'll give you an example there, that in Nigeria, I work personally with the president of Nigeria, and he has invested a substantial sum, billions of naira, to feed every school-age child in Nigeria. We're now in 20 states, feeding 7 million children a day with a hot meal, provided by the smallholder farmers, which are invariably the parents of the children that we want back in school. This is working. And he is now talking with Ghana about how to scale up in Ghana. How do we scale up more in Nigeria. Nigeria wants to go to 70 million children by the end of this year, 2018. That will be a fifth of all school-age children in sub-Saharan Africa being fed a hot meal, a hot nutritious meal every day. And and they're wanting to feed their own children. They're putting their money behind it. So us as technical assistants should be the people just providing the evidence to make sure that it's done right. And it is, and it works. Next slide. So we come back to GPE, and GPE's version of the DCP3 is wonderful and has been totally taken up by lots of policymakers across Africa, across Asia. And the project that they have been working for the last 3 years is the SHIP, which is the School Health Initiative Integrated Approach. And what we tried to do there was to look at 2 simple interventions, deworming and provision of glasses to kids in schools, because we knew they have education implications, but we know how to do it. And so we know how much it costs, we know how to train the teachers to do it, and the 5 countries now are saying, well, this is a really strong platform, and we want to move forward and make the school health and nutrition program a lot more comprehensive than just this. And so GPE has really been the flagship bearer of trying to integrate school health and nutrition into education sector plans. And the key piece there is always to use the communities, make sure that the communities know what they're doing, what's happening with their kids in schools. How do we move forward? Next slide. So as part of this GPE World Bank initiative, we have developed guidelines that the countries are looking at and wanting to adapt to their own context. But it's not just about school health for all. There's specific pieces about school eye health, school-based deworming, and also about how we get the teachers to understand this. Next slide. So another example of scaling up, we started in India's state of Bihar looking at just deworming. And the key thing there was making the Ministry of Education and the Ministry of Health at the highest levels work together. And we had success. 17 million school-age children were dewormed in Bihar and continue to be so over the last 3 or 4 years. That has now gone to 220 million children as a national program. So we need the evidence, we need the political backing, and we need the capacity. And we can show that, and we've shown that we can do that as a school health community. So strongly advise you to read this paper because it's ace. And I wrote it. Next slide. So we have a window of opportunity here. So what we want to do is look at putting school health and nutrition into education sector plans. And so the education sector knows how much it costs for curriculum. It knows how much it needs for textbooks, examinations, etc. But we don't know enough at the country level how much we should put into school health and nutrition as part of the education sector plans. Many countries are running with this right now and putting the evidence there and calculating the costs. And DCP3 and the DCP3 education version is really like their Bible at the moment. And what we need to do is support the countries in making sure that we don't close this window and make sure that we have school health and nutrition in the education sector plans as we move forward. Next slide. Next slide. So my main message is we can do it. It is scalable. It is sustainable. And a key thing that we can do is move forward in integrating the school health and nutrition piece into the education sector plans. But we need to help the countries make sure that is evidence-based, it's properly costed, and agreed with the education sector. But together we can move forward. So one thing that I would like to do is just to pull us all together to make sure that we have those right messages going out. Thank you.
For helping us to understand what the packages of school health investments look like for children of different age groups, and particularly pointing out the economic and educational impacts. I was very particularly noting that we can do it, it's scalable and sustainable, and we need to get it into education sector plans. I'm aware that there are some questions coming in, so I'm going to hand over to my colleague, Michelle Mason, to moderate the questions. Thanks, Michelle.
Thanks, Jane. Thank you to the presenters. We have some questions coming in online. Jimena Jesus is asking if it's possible to have the paper, book, or documents referring to the importance of investing in the 700 days. Don, for you.
Sure. Do you want us to take one at a time? I'm happy to do that. Let me do that. First of all, let me just say it's 7,000. It's 7,000 days. So, and you know, the concept there is we're all familiar with the 1,000 days. The 1,000 days couldn't be more important. That's really important. Those first 1,000 days of life, vitally important. But we're now realizing that the next 7,000 days are also important. Growing a human being doesn't take 1,000 days. It takes 8,000 days. And growing a human being is the exercise that we've often talked about as parenting. You know, it's if you talk to parents, they totally recognise you need to invest throughout in a child. You need to invest in education, you need to invest in health, and you need to invest in both of those things at the same time. So I think that's probably the most important message from the piece. All of the documents, all of the information is available on the website. It's actually unusually user-friendly, set up by the World Bank. It's called so it's www.dcp, disease control priority, DCP-3. DCP-3.org. Everything is downloadable from there, and it's all free. You can download it as individual volumes or individual chapters. So it's all there. It's all very easy to use.
Great. Thank you, Don. We'll make sure that in the communication materials that we send out after this webinar that we also include that link. Thank you for that, and thank you, Jimena, for the question. The next question is for Leslie. It's coming in from Zeni Zanash. She's noting that an SDC in Albania is planning to start an intervention on health promotion and NCDs prevention in schools, targeting ages 6 through 14, with a focus on behavioral risk factors, specifically unhealthy nutrition, smoking, tobacco, and lack of physical activities. But from your presentation, she notes that she sees that this is mostly tackled through ages 15 through 19. Their idea is to start from the ages 6 to 14 before children engage in risk behaviors. Now she's wondering, is this the right approach?
Is a very, very good question. I think we should start early with health education about risky behaviours. And so a review is being commissioned by UNICEF, I think, on health education curricula. And I think we should look at what are we teaching our kids in the schools when we've got them there to stop them behaving in risky ways. And so I would say there's two steps. First of all, we need to do it in school, but secondly, we do need to explore this youth piece. We need to look at where are the youth getting their information. If we've lost them from the school system, where are they now, and how do we address the issues that are critical to them? And case in point, Albania. Why don't we? A question back would be, where are the places that youth go to in Albania for information, and can we give them better information?
Great, thank you very much. And thank you to Zenny for the question. Another question for you, Leslie, if I can. It's coming in from Tom Vandenbosch. He's asking whether the deworming debates, controversies have come to a final conclusion.
So I think Leslie's suggesting that I take that one. So, these debates will never come to a conclusion, right? I mean, these are academic debates, so we would expect those to continue. What has happened, though, is that the World Health Organization commissioned a new guideline on school-based deworming, on deworming generally, but including school-based deworming, in which they involved the various parties that were involved in this debate. Both sides of the debate were present and part of the discussions going forward. And the conclusions that the WHO came through after this quite extended consultation process was that deworming was indeed a part of the practice in addressing health, particularly in school-age children. That the original recommendations that they'd made continued. That's the basic message. And let me just underline to say that there was never any contention. I think this is often misunderstood. There was never any contention that it was worthwhile deworming children. That was by all sides of the debate. There was agreement about that. The debate was how significant was the effect, and how well could you detect that effect if you were looking at populations where you treated everyone, whether they were heavily infected or lightly infected. So I think in one sense we've come to a conclusion because WHO has come out with a clear policy directive, but I've no doubt we'll continue to hear this interesting debate go on. But I want to say that I'm hoping within the next 5 or 10 years it'll no longer be an issue anyway, because many of these diseases will have been severely curtailed. So I think the answer is last year 1,000 million children were treated for worms while the debates continued. So I think I think what's happening is the countries are making their own decisions on this one.
Thank you, Don, and thank you, Tom, for the question. We have another question for both Don and Leslie coming in from Neil Lazrak from the World Food Program. He's asking several chapters of the DCP3 highlight the role of school meals. Could you please tell us why they are so important from a health perspective and why nutritious meals can improve not only access to education, but also learning outcomes?
Okay, Linda, could you just pull that slide back for me on school?
I don't think that's difficult to do.
Yeah. Apparently that's difficult. So school
We'll bring it up.
If we turn back the clock and look at when the food, fuel, and finance crisis happened, there was a $1.2 billion fund put together by the World Bank for countries in crises to use for their own needs. Every single country used some of those funds for school feeding. And so even the World Bank, who saw school feeding as a real hot potato, as a political thing, it's too expensive, we don't want to deal with this. They had to rethink it in terms of why countries are using it for school feeding. And it's not just about the health and nutrition of kids, it's about the social safety net issue. And it's about getting kids back into a safe school environment. And so if you add then on that the idea that it's an investment in rural economies, it's the parents that benefit because they're providing the food on forward contracts from the government, then everyone's a winner. So school feeding works. It works in terms of making kids not hungry so they can learn, they're in school, and it's benefiting their own community. So I'm a great believer in this. I'm a great believer in homegrown school feeding. So why can we not develop menus that can use local foods produced by local parents that are paid by the governments, that get the kids back into school, and they get fed for free, but they also get educated. So it seems to me it's a win-win.
Thank you, Leslie. John?
Yeah, so as Leslie said, in 2008, when the price spikes happened on food in low-income countries, the so-called rice crisis, the World Bank set up a fund which countries could take advantage of to ensure that there weren't nutrition consequences of this. It wasn't every country that came forward and said they wanted school feeding, but the point really is that the World Bank thought that the questions that would be asked would be around the idea of subsidizing food and so forth, but it turned out that countries saw school feeding as an important social safety net. And so the slide that I think Leslie wanted to show is one that shows that school feeding, the benefits from school feeding are in fact fourfold. They're the nutrition ones that people talk about, but those are probably the least clear-cut benefits. Very significant education benefits, particularly for girls' participation in schooling. Very significant returns as a social safety net, probably the main purpose for it. And recently, excellent evidence showing that provided you use homegrown school feeding, in other words, food grown locally, and certainly in the same country where it's being used, you also inject finance into the economy. So there are multiple benefits. Which mean that the cost, and let me be clear here, the cost should not necessarily be borne by the education sector for school feeding, because there are so many other sectors that benefit from it. So it should be seen much more as a social protection, intervention. And I just want to add a point to that. We should never allow school health or school feeding to be a tax on education. We should see it always as an investment in education. If this is having a negative impact on education, then it's not being done properly. So I just think that's very important.
Thank you, Don, and thank you, Leslie. Just handing it back over to Jane.
Thanks very much, Michelle, and to all our viewers for sharing your probing questions. We will have a further round of questions following the next two presentations, so do please keep your questions coming. I'd like now to welcome Ms. Alice Albright, Chief Executive Officer of the Global Partnership for Education, and invite her to please outline the key linkages between the DCP3 volume and achievement of the strategic goals of GPE's Strategic Plan 2020. Thank you very much, Alice.
Thank you. Thank you so much. Today or this morning is definitely a time where I feel like I could be many places at once, because I would have happily been with you all morning and later on, but I can't. But I'm delighted to be with you for a little while. I think that the DCP3 is a huge contribution, and I think it's a very something that everybody should be looking at in terms of guiding our work. And just to sort of give a bit of context on this, certainly from my previous work, it is obvious to me about the connections between health and education. I often like to tell people, and I have it in my hand for those who are on the webinar, I have a letter that I received from a chief in a village in the Congo about 3 years ago, when I went back to visit the school that we helped them build, and it was in a very remote part of the Congo. And the letter says, it's right here, I won't read all of it to you, but I keep it on my bulletin board. And it says, thank you so much for the school. Next time, can you also build us a hospital, because we don't have one, and you could build it right next door. And it just reminds me how interlinked these issues are. And it's not just because they were in a remote area and didn't have either a school or a hospital. They knew that there are linkages. And so what are the linkages? Clearly, providing better health will take away barriers to children getting educated. It will level the playing field. Clearly, thinking about health and education together will have, I think, an important impact on equity. And one of, obviously a key component to that is gender. There are barriers to girls getting into school which are very related to health issues. Menstrual hygiene, for example, is one of them. Also, there are clear synergies between a health platform and an education platform. So I think I'm preaching a bit to the converted here. I know, Don, you certainly are very much in agreement with me on this. But working on these two issues together, developing the technical tools, the advocacy tools, working with governments, we should all be thinking about these two issues very much in concert with each other, because it is just so obvious. And I know from a GPE perspective, we certainly think that. I'm very excited. We're about to start doing a stock take. It's yet another thing where I'm going to have to prevent myself from spending too much time on it at the expense of everything else, but it's something that I'm totally interested in, and delighted to support the community, support ministries, to try to really forge these linkages, because it's absolutely obvious when you look at the evidence, when you talk to people in the field, when you hear from people in villages, that these two things belong side by side with one another. So thanks for inviting me. Good luck with your work, and I can't wait to hear and see what comes out of all of this. So thank you.
Thank you very much indeed, Alice, for sparing time to be with us this morning. We know you have a very full morning of other meetings, and we very much appreciate you sharing your reflections on how the strategic investments in health can lead to better education results and greater gender equality and equity. So thanks so much for that.
Yes, absolutely clear.
Thank you.
All right, well, enjoy the rest of the webinar. You all take care. Best wishes, and thanks for all the hard work, and I will look forward to hearing a download.
We will certainly be
providing
that. Thank you, Alice. And our final speaker this morning is Ms. Linda Schultz, Health and Education Consultant at the World Bank headquarters here in Washington, D.C. Many thanks, Linda, for giving us a preview of what's coming up next in the following 2 webinar sessions on this theme.
Thank you, Jane, and thank you for the opportunity to join the distinguished panelists on this webinar. If you have enjoyed hearing about the synergies between investments in health and education this morning, which we hope you have, we hope that you'll join us for the 2 additional webinars that are scheduled for May 31st and June 28th. To give you a sense of what's to come, as Don mentioned, the Disease Control Priorities 3rd edition includes essential packages across the 9 volumes, and collectively there are 21 essential packages. In the next webinar, which again is scheduled for May 31st, we'll be taking a deep dive into the essential packages that Dr. Drake gave us a great introduction to. We'll do a very brief overview of the early childhood package, the school age package, and the adolescent package, which are presented or proposed within the Disease Control Priorities Child and Adolescent Health and Development volume. Very briefly, the early childhood package builds upon the package that is proposed within Volume 2. Volume 2 looks at maternal, reproductive, and child health, and discusses parenting programs and encourages responsive stimulation during the first 1,000 days. As Dr. Drake gave us a preview to, the school age package addresses the needs in middle childhood and early adolescence through school-based approaches, and that covers ages 5 to 14. And the adolescent package focuses on older adolescents through a mixed approach that involves communities, secondary schools, media, and health systems, and that looks at ages 15 to 19, And in practice, you would have both the school age package and the older adolescent package together to reach the needs of adolescents, which are defined as ages 10 to 19. What's really exciting is that those discussions will be led by the economists who put these packages together, who thought through the evidence as to what was feasible and scalable in a low resource setting. And those discussions will also be complemented by some specific country examples to help contextualize the essential packages. Then moving on, our third and final webinar in this series will explore evidence on interventions in middle childhood and school-age children. One of the presentations will look at specific examples from the literature to assess whether interventions in the early years of life can help children regain or approach their innate capacity for development. And this is particularly of interest as you think about the potential for interventions during school age to affect a child's later development. Another presentation will explore disability in middle childhood and the opportunity for education to be a gateway to fully participating in society. And this discussion is timely as we look ahead to the first Global Summit on Disability, which will be held later this summer, and as we work towards achieving the SDG target for inclusive and equitable quality education. And lastly, we'll explore human development during the adolescent years and health interventions that demonstrate the potential for adolescents to remain in school. And each of these presentations will be led by thought leaders in these areas and by contributors to the Disease Control Priorities volume on child and adolescent health and development. So we hope that you'll join us on June 28th. And as a final parting note, as Dawn mentioned, all of the materials can be downloaded for free on the Disease Control Priorities website, which is dcp-3.org. So you can download the volume, individual chapters, as well as optimizing education outcomes. So we hope that you will make full use of those resources. And in addition, there is a Lancet publication that neatly summarizes the main conclusions from the volume. So thank you, and we look forward to having you with us again on May 31st.
Thank you so much, Linda. I think you've made us all very hungry for more. We're very much looking forward to the next opportunity to come together and take a deeper dive into this key strategic theme. May I ask Michelle to lead us into the final Q&A session? Thank you.
Sure. We have a couple of comments that have come through. Kate Molesworth from Swiss TPH notes, for poor families and settings, food provision through school feeding is a major incentive for parents to release their children from productive labor, especially girls, for education. She notes, we are working on menstrual hygiene in Dodoma, Tanzania. You're welcome to contact her directly if you have any questions about this subject at kate.molesworth, MOLESWORTH at Swiss TPH, that's SWISSTPH.ch. Thank you, Kate. Marieke Boersma from Light for the World notes, the issue of school dropout and lack of menstrual hygiene is an issue we have found out is a big issue for girls with intellectual disabilities. Many parents do not think of them as becoming women, and when it happens, many parents do not have the language to deal with it. Does anyone have good materials on the topic? So thank you again for Kate for responding to that question from Marieke. Just wanted to open it up and see if anyone else on the panel had any additional materials that they might be able to share or know of.
Hi, this is Leslie. I think this whole issue of menstrual hygiene for girls is something that we really need to address. And Jane, I know you have strong feelings about issues there, but it is a key point, a key reason why the girls are not coming to school. And there are guidelines, but I think what we need to look at is practicalities and how do we practically get the needs, the menstrual hygiene needs to the girls in countries where there are no sanitation, there are no sanitary packages, they don't even have the right clothes. And it's something that if we're trying to get the kids back into school, the girls back into school, it's something that we might want to focus a new priority on. Jane, I don't know what you think.
Well, I really support everything that you've just said. We were at a workshop together recently in Addis Ababa, and we were fortunate enough to listen to the different interventions that countries were implementing on school health and nutrition. And we were very interested to hear from Zambia, for example, who had done the research to show that 80% of the girls said they missed school because of their menstruation. So they'd identified it as a key barrier. And what we understood from the Ministry of Education there, that they were addressing this through a national government-supported program to actually provide the sanitary pads, which, as you say, are not available. And we'd like to have more information about this to see how they're also addressing issues such as safe disposal of different products and dignified facilities. So we're very much hoping to hear a little bit more about that. And, I am reminded that 28th of May is Menstrual Hygiene Day. And, it would be good to showcase, I think, some examples of countries which are working on this key issue, which is such a tremendous barrier to girls, not only for education, but fulfilling all their potential in life. I'm not sure if we have time for one more question. I have a question that I would like to put to you, if possible. You've, I think, pointed out one very key area where interventions in school health have benefits for girls, especially adolescent girls. I wondered if you could elaborate a little bit more on some other specific areas where you have targeted interventions which benefit adolescent girls. I'm thinking perhaps in terms of iron deficiency, nutritional supplements and so on. Could you tell us a little bit more about how adolescent girls can particularly be benefited from these interventions?
So, always talking from the programmatic context, in Nigeria, what they're doing is specifically focusing on these issues for girls and looking at, and Ghana, and looking at putting supplements in the school feeding program, for example, in Ghana, but also looking at more practical health education, sex education for girls, not just in the schools, but out of the schools and in the out of school clubs, and using the materials that actually make sense to the girls as opposed to the things that come out of textbook. And maybe this is what we should be trying to put together as a note on advisement to girls, and to teachers and how to deal with these specific issues, because I think it's really lacking. It's a good question, Jane, because I think the girls are just running away from it and they don't know. And one particular thing I want to raise is the data coming back from South America is that deaf girls have an increased risk of early pregnancy and HIV incidents, and it's because they don't have they just don't know what sex is. They don't know about HIV, and they're in a microcosm of a hearing deficient population, and their incidences of HIV and early pregnancies are through the roof. And so there's a really good piece coming from South America that we want to try and translate to sub-Saharan Africa to try and make sure that these particular kids get that message, but maybe we should be making it wider, and maybe we should be putting a paper together as a school health nutrition community to say, how do we reach these young females and young males? I don't think we should identify it as a gender thing. How do you deal with this?
Well, thanks very much, and yeah, we'd be very pleased to collaborate on such a paper, I think, and as you say, with a very gendered focus, so not just getting the messages to the girls, but making sure it's supported by boys having the information they need. Michelle, I think a comment's coming in.
Yes, thanks, Jane. Thank you again to Kate Molesworth from Swiss TPH. She's noted that within the Swiss project, they have successfully encouraged schools to provide pads within budgets, to provide disposal within sanitation hardware, and to include the topic in teaching and learning. So thank you for sharing that information. She also has shared her contact for those who have more questions about this project. Again, this is a project that's being worked on in Tanzania. And Kate, thank you. It's kate.molesworth@swisstph.ch. Thank you, Kate. And if it's okay with you, we'll share your contact information also when we circulate materials on this subject. Thank you.
Very much, Michelle, and to all of you for your very searching and thoughtful questions and comments. I'm afraid we are running out of time now, but please remember there'll be 2 further webinars, as Linda has outlined, to come on this theme, so there will be further opportunities to be in touch. I'd really like to give tremendous thanks to the presenters this morning for their very informative presentations, and to all our participants around the world for joining us today. It seems to me that, together all the panelists have really very strongly succeeded in establishing exactly why education stakeholders should be paying attention to the health investments outlined in the DCP3 volume. We heard from you, Don, health matters for education, education matters for health, and especially for girls is what we've heard, and especially to have a positive impact on equity. Which is what we heard from Alice. Alice mentioned that the 2 things, it's very clear that they belong side by side. Education and health go hand in hand. So I think, there's a clear implication that we need to work very closely together to get the best results for every girl and boy. A key takeaway from me was, while the first 1,000 days are critically important, and we should not, in any sense, take away investment from those early years. Don, you mentioned it takes 7,000 days to grow a human being, so that we need to invest more in health and nutrition throughout the first 20 years of life, not just the first 2 or 3. Leslie, I was very struck by your comments. We can do it. It's affordable, it's scalable, it's sustainable. And that was underlined by Alice saying it impacts equity and gender equality, so we should do it. And I think the key message was that to maximise the impact of these investments, it must be integrated into the education sector plan. We very much encourage everyone to take a deep dive into this very informative volume. I know that it's got over 200 pages, so if you have no time to read anything else, please read chapter 20, which Leslie outlined, is looking at the school as a platform for addressing health in middle childhood and adolescence. Do please join us for the next 2 webinars. We've got an exciting menu coming up, as Linda has outlined, and we very much look forward to seeing you again soon.